the low flow anesthesia part. So what I would like to do over the next 12 minutes or so is share with you the basics I learned over the last 35 years and how I extended my view on low flow. Now, why do we want to use low fresh gas flows? Well, obviously, the lower the fresh gas flow that you use, the lower the amount of inhaled anesthetic, liquid sevoflurane, you need to, in this case, maintain anesthesia for 1 hour with 2%. So a proportional reduction in usage as you lower your fresh gas flow, which will obviously reduce cost and pollution. Oops. How low can we go? What's the lowest possible fresh gas flow and sevoflurane amount we need? For 1% or for 2% over 1 hour, it's 7 milliliters of liquid sevoflurane, 6 ml of which will be taken over the patient, and 1 ml which is used to prime the circuit in the lungs. And the lowest possible fresh gas flow we can use is 180 milliliters per minute, which is the average oxygen, which is the oxygen uptake of the average adult. So this is the lowest we can go. This amount is directly under your control. When this is the amount taken up by the patient and needed to prime the circuit, this is the amount that's directly under your control by manipulating the vaporizer. So how do I perform low flow? Well, first let's consider manual control, where you are going to control the vaporizer, the fresh gas flow settings. It requires a little effort and understanding of a few basic principles. So what are these basic principles? I'm going to explain this by having a look at how I have to adjust my vaporizer dial setting, for example, sevoflurane, or doesn't matter, that's your agent, to deliver traction over time with either a low fresh gas flow or a high fresh gas flow. So how do I have to adjust my vaporizer dial setting to get exactly the same expired agent concentration? If you use a high fresh gas flow, you can lower the vaporizer pretty fast because the washing is really fast. With a really low fresh gas flow, you will need a higher vaporizer dial setting to compensate for the slower washing, and it will take a little bit longer. You could consider using high fresh gas flows here, but that comes at an incredible amount of waste. In just 3 minutes, you'll be wasting as much as you will be wasting, as you will be using over the rest of your low flow anesthetic. You will, compared to a high fresh gas flow, need to use a higher vaporizer dial setting once your fresh gas flow drops below 1.5 liters and especially below 800 milliliters per minute. And why is this? The lower the fresh gas flow, the more exhaled gas will be rebreathed. The agent has been taken up by the lungs, so the concentration of the agent in the exhaled gas has been lowered. The exhaled gas will be re-inhaled and will dilute the concentration of coming from the vaporizer and the fresh gas flows from the common gas outlets. So in order to compensate for this dilution effect, you have to increase the vaporizer dial setting. You will also note after the initial wash-in phase that during the first 10-15 minutes you will have to, compare to high fresh gas flow, where you barely need any vaporizer dial settings, you'll have to continuously reduce your vaporizer dial setting a little bit or a few times, and that is because the vessel-rich group, heart, lungs and kidney, saturate and uptake decreases very rapidly. So you have to turn down your vaporizer a little bit more with low fresh gas flows because the effect there is more pronounced. Then we go to the maintenance phase. With high fresh gas flow, the vaporizer dial setting will be more or less the same for all the patients, but if you go well below 1 liter per minute and below 500 milliliters, you will see that in some patients you will need almost double the vaporizer setting compared to another patient, and that is because of the same entitled uptake by the patient differs by more than 100%. Finally, if you want to change the end-tidal concentration during the maintenance phase with high fresh gas flow, it's just a simple small adjustment in the vaporizer dial setting. With high fresh gas flow, you may be inclined to make larger vaporizer dial setting changes to compensate for the slow effect. And this will actually cause the end-tidal to oscillate a bit, because you will see the effect on the end-tidal, then you will adjust again, and you will make a few adjustments, and this is inherent to a feedback system. You get some small oscillations. And of course, the same principles that apply to inhaled anesthetic agents applied to the oxygen. The inspired oxygen concentration, which you measure with a gas analyzer, will no longer match what you dial on the flow meters. Again, because of this dilution effect. Dilutional effect, you can get inspired hypoxic mixtures. So how do we manage that? Well, let's say you want to maintain an inspired oxygen concentration at 30%. As you lower your phase gas flows, you will have to increase the proportion of oxygen in the total air-oxygen mixture to make sure that you maintain this 0.3%. So this is what you have to do by adjusting the flow meters to make sure that you maintain 30%. And you can see here that once the phase gas flow drops below 1.5 liter, and especially below 1 liter, that's where you really have to make the major adjustments. But once you know this, it becomes really, really simple. These are all the secrets you need. Never, ever deliver inhaled anesthetic agent prior to securing the airway. It's pure waste. If you do anything, just give some additional propofol. Never, ever give inhaled anesthetic prior to securing the airway. So after securing the airway, start with the first gas flow of 1 liter per minute. Vaporizer at 8%. Watch your end-tidal agent monitor. Lower the first gas flow down to a level you're comfortable with. Then start adjusting the vaporizer, again using your gas analyzer, and apply the principles I just outlined, and that's really it. And then with regard to the oxygen, just adjust the proportion of oxygen and air in the fresh gas flow mixture. It's really that simple. That's how you make the operating room green. But of course, if you don't want to be bothered by this, you can just use a target-controlled anesthesia machine. And if you want to see, so where has technology led us? Well, you can just walk out of the door, and they're all there. I did studies with all these machines, but not with the Mindray A9 because I've never been able to work with it. So where did these machines bring us? So here again, the amount of single fluid we need, that's the lowest we can go. You can see that in target control mode, all workstations do a great job at reducing the waste to near closed circuit conditions or near to near closed circuit conditions. So mission accomplished. So we have this technology to really just deliver that amount that we need. But I would like to extend our view a little bit on how we can minimize the environmental impact of inhaled anesthetics. Low flow is the key piece to reduce environmental impact, but there is more that we can do to minimize waste. And I refer to this with the word low flow puzzle, and get a proper understanding of the contribution of CO2 absorbers. This will be addressed by Jennifer Jumina. Consider leak sources. Jan Hendrickx will talk about them. After securing the airway, allow the end expired concentration to rise slowly. By allowing it to rise slowly, there is no need for high phase gas flows, and that will help minimize waste. Remember, just after securing the airway, the propofol and opiate concentrations are still high, so having temporarily less than 0.7 mic, which is what you need to ensure unconsciousness, is okay, because there is synergistic interaction between the inhaled anesthetic that's rising slowly and the propofol and the opioid still around. And do realize that there is a delay, so that's synergy. And also do realize that there's a delay between the end expired agent concentration and the brain concentrations, that hysteresis. During the maintenance phase, I rarely use more than 0.7 fraction of a mic these days. If you use 0.7 instead of 1 mic, you're reducing your waste by 30%. So it's a powerful additional tool to minimize waste and properly titrate your opioids using synergy constants. And then finally, at the end of the case, a while before the anticipated skin closure, switch off the vaporizer while maintaining a low phase gas flow, a technique called coasting, and your end expired agent concentration will decrease slowly, maintaining anesthesia for a while without vaporizing another drop of liquid. All these processes involve hysteresis and synergy, which can be monitored and steered by Mac Brain, which Andrea de Wolf will address, and by personalized fraction of a Mac titration. Remember, again, lower fraction of a Mac, less waste. So how can we seek the lowest safe fraction of a Mac in the individual patient? By taking hysteresis and drug interactions into account, using visible drug display systems and processed EEG. And that's what Rick Carrette is going to talk about. I called him here the 0.5 fraction of a Mach man. So we'll look forward to his lecture. Finally, monitor your own progress, cumulative. So see how you're doing yourself. Ross Kennedy will address that. If you want to see how your department is doing or your country, use big data, Tom Sally. Of course, if there's waste, just kill it. And Ole John Nielsen will talk about it. Or maybe you can capture and recycle it, which will be my topic. Thank you.
Yeah, thank you very much, John.
I have 2 more slides. I forgot.
Oh, sorry.
So I use, So I use 4 milliliters of liquid. That's what I use. Okay? Important take-home message. Yeah. Wake-up call from myself. Let science lead the discussion with TIVA and inhaled anesthetics. And don't forget to apply the clinical pro and pro-con balance after you have finished your life cycle analysis discussion. Use data and common sense. This is not how I do receive a fluorine mass conduction. Okay? So, and that's it. So this is what I just walked you through, and I now look forward to the other speakers going deeper into the points I raised. And now I'm done. End of slideshow.